So the next speaker will be Dr. Doris Leung. I hope I pronounce your name correctly, Doris. And she is the successor, let's say, of Katri Wagner, who was always involved in adult care in the US. And she will speak about the USA Certified Duchenne Care Center for Adult DMD. Welcome. The floor is yours, Doris.
Thank you so much. I'm going to share my screen. Thank you so much for inviting me to this conference. I'm Doris Leung. I am the director for the Center of Genetic Muscle Disorders at the Kennedy Krieger Institute. I'm also on faculty at the Johns Hopkins School of Medicine, and so I practice here out of Baltimore, Maryland. I have a slide that has all of my disclosures, but I will also take this as an opportunity to describe our center a little bit, where we have a large multidisciplinary clinic. We're one of 30 certified care centers that have been certified by Parent Project Muscular Dystrophy. We are the first center to be certified for both adult and child care. So if you have muscular dystrophy, we will follow you throughout your life. This is something I've heard other presentations allude to. We also run a very active clinical trials program. And so most of the disclosures that you see here represent industry-sponsored clinical trials that will hopefully bring new drugs into the muscular dystrophy space. So in deciding what I wanted to talk about, I really wanted to address issues that are, one, kind of specific to adult care, but also specific to the United States. So like whatever is in the middle of this Venn diagram here. And I think the care recommendations are not substantially different from what they have been in other countries. I think the differences in care are largely created by the healthcare system in which we're operating. So I will talk a little bit about that with a focus towards how it affects these particular topics, transitions after post-secondary education, and advanced medical management. So since I have a whole 15 minutes, that's plenty of time to describe how the healthcare system works in the United States. I am kidding. This is a very, very complex topic, and I am not an expert in it. But I do think that a little bit of understanding about the health system factors that are at work really kind of understand why care is the way it is in the United States. So about half of Americans have private insurance. This means either the individual, but usually their employer, pays a monthly fee to an insurance company that will in turn pay the bills when a patient gets medical services. Okay, there are about 1,000 healthcare insurance companies in the United States, but there are 5 very large ones that each have about somewhere between 7 to 12% of the market share. So if you have private insurance, federal law states that a dependent child can stay on a parent's plan until the age of 26. Okay, and so that's one thing that I think is very relevant to our Duchenne patients. So what's interesting about private insurance is about 60% of this group, the employer is actually self-insured, meaning that the insurance company has some sort of administrative role, but the employer themselves pay the medical bills. And most of the large companies in the United States are self-insured because it gives them much, much greater control over the cost. So if you work for Amazon, if you work for Facebook, if you work for Disney, if you work for Apple, you have a self-insured employer. However, if your company is not huge, right, having just a few employees that need very expensive medications can in fact wipe out the whole healthcare budget that was intended to pay for medical care for the entire company. And so that's another factor that I think is important to know. So other types of insurance, right, for the other half, about just under 1/5 of Americans are enrolled in Medicaid. And many of our patients fall into this group. Medicaid is actually funded by the US government to insure very specific groups, including people with disabilities. However, Medicaid is administered by each state. So there's not one Medicaid program, there are 50 versions of Medicaid. And so, the types of coverage that they have will depend on what state the patient is living in. So another 1/5 of Americans are enrolled in Medicare, which is actually a truly federal, government-run insurance program that is intended for retirees who no longer get insurance through their employers. Eligibility for Medicare begins at 65. So most of our Duchenne patients are not on Medicare, obviously, but as the largest single insurer, Medicare actually controls the weather in terms of how much hospitals and physicians and care providers get reimbursed for medical procedures like ECGs, like bone density scans, like pulmonary function testing. And all of the other health insurers in the United States will use the Medicare policy as a starting point for how much they are going to reimburse for medical care. For instance, Medicare does not cover the cost of most genetic testing. They will not cover the cost of most genetic counseling that is independent from a physician. Which is why there is a huge amount of variability over whether or not genetic testing can be paid for by insurance in the United States. And there are many health insurance companies that do, but many that don't. On the one part that they have less control over is actually the cost of prescription drugs. Medicare is the largest purchaser of prescription drugs in the United States, but federal laws prohibit it from negotiating drug prices with manufacturers. And so I'll let you think about what that means. So I think the takeaway here really is that there is no one US healthcare system. It is actually hundreds and even thousands of systems, and any one patient's coverage and what their insurance will pay for is determined by things like where you live, who you work for, how old you are, and the political climate at any given time. And this is the environment that the US providers will practice in. And the complexity of this system really permeates every aspect of patient care. It determines who is on deflazacort versus who is on prednisone, who is getting viltolarsen versus who is getting golodirsen, who is getting a power chair that has lift, tilt, elevate, but who is getting one that has standing function as well, who is getting one that has robotic arms attached to it. And consequently, there is sort of like no one way that US providers can manage muscular dystrophy. Each patient is his own system, and we work on figuring this out together. So hopefully that has not scared you off too much, but I'll talk a little bit about how does this impact the care in adults with Duchenne muscular dystrophy. First of all, it is important to know that schools from kind of kindergarten through age 12 provide a number of medical services under the Individuals with Disabilities Education Act. They will provide specialized instruction and case management, assessment of learning disabilities, and physical therapy and occupational therapy through schools. So colleges and universities, and certainly not employers, they are not required to provide these services. And so schools should be starting to transition these services and start planning to shift those services to other providers around the age of 14. And part of our role involves helping students navigate these transitions. Okay. And so there are many, truly many options for sort of what happens after post-secondary school. Kind of the ones that I wanted to talk about were higher education and employment. And there are numerous options. There are over 4,000 institutions of higher learning in the United States, and you can get an education in most topics, right? Whether it be through four-year universities, community colleges, vocational training programs, and I have had patients who have done all of those things. Similarly, I think that there are increasing opportunities for employment. And so I have patients who work fully remotely. They work entirely from home. Some of them actually will commute to work and will actually go to work in an office, and others will, also move away from home and live away from their parents as well. And there are a lot of ways to that I think are important to ensure that this type of transition is successful. And the first part is really doing your research. All schools are different, all employers are different, and some do a much better job in terms of meeting the needs of students and employees with disabilities. And so, students looking to go to universities and colleges should consult their disability services offices, and employers, patients seeking to be employed would turn to their human resources offices to discuss what their accommodations need to be. So the major relevant legislation in the United States that has to do with disabilities is the Americans with Disabilities Act. And it was passed in 1990, and it applies to both schools and employers. So any system where many companies will actually pay the cost for their employees' medical care, there is an extremely high risk for discrimination against people with disabilities because the cost of their care can be higher. And the Americans with Disabilities Act prohibits discrimination in hiring and in admissions to colleges and universities, and mandates reasonable accommodations for people with medical disabilities. Now, determining what these accommodations are and requesting them is really a skill in and of itself. And so this is something that we get a lot of practice in as a muscular dystrophy provider. But the key to the accommodations is that you need to present it in such a way that it is enabling a student or employee to successfully perform the essential function of their schoolwork or their job. And I think in order for this to really work well, it's absolutely necessary for patients to take on more of the decision making and communication with their school and with their employer. The school engages with the student directly. The employer engages with the employee directly. They do not engage with parents on behalf of their children. And this doesn't mean that the parents are out of the loop entirely, but they just cannot be as involved in sort of the day-to-day decision making. If they, even if the patient has care attendants that are with them throughout the day, their role is mostly restricted to their care needs, and they cannot be a proxy for their parents either. And so there can be real struggle in adapting to a college schedule because it's very, very different from say a high school schedule. And with kind of every period, every hour is very strictly managed. In college you can have these very, very large periods of unstructured time. And some people really struggle with budgeting their time in that sense. But those who can engage socially and academically find it so worthwhile, and it's really tremendously rewarding to hear about my patients. And these these successes aren't necessarily academic. Some of them are actually kind of questionable. It's like I have had patients who have stayed out until 3 o'clock in the morning partying. I have had patients who have gotten arrested in, peacefully protesting government policies. And I am not saying that they should do these things, but there is a small part of me that sees this as a win. Because I know that their parents had nothing to do with this, and so it's in some ways I do like hearing these types of these stories because it really does demonstrate a higher degree of independence. And that translates into their medical care too. We try to facilitate as much autonomy as possible. And this can mean having appointments without their parents, encouraging them to communicate with me directly, but through email to get their medication refills, and helping them feel like they can make decisions even if they go against what their parents want. And I think we do need to acknowledge that there is a tension here, because as these patients are getting older, they do need more people involved in their care, both in clinic and at home. And that is one of the reasons, our center has engaged a standing palliative care consultant. And I think, across the US, palliative care is actually very underutilized, and even more so in Duchenne muscular dystrophy. In our clinic, much of their role is advanced symptom management, hospitalization planning, and a major part of their job is helping patients clarify their goals of care. So not too long ago, when I was in training, I was seeing a patient who was in his 30s, and he was hiring someone and teaching them how to do his morning routine. And I said, well, it's great that you will have a backup, for your parents. And he told me, he says, and he said to me, it's like, well, let's face it, my parents aren't going to be around forever. And it made me feel so many things, right? First of all, sort of this existential sadness of having lost a parent myself, but also this recognition of how much the field truly has accomplished in managing patients and prolonging their life expectancy to the point that I now know that I have patients who will outlive their parents' ability to take care of them. And I'm not sure that even a significant minority of my patients have seriously thought about this. But some of them clearly are. And as their physician, I want to be open to and facilitating these kinds of conversations, and really be educated about what these options are within their healthcare system. So that is my last slide. I definitely wanted to thank you again for the invitation to give this talk. And I look forward to your questions and to the discussion session.